We're now into week 10 of the course, and this week we look at the U.S. healthcare system and we'll pay special attention to Medicare and Medicaid, how those programs operate. But before we dive into the course content, I'd like to remind students that their SACS reaction paper is due next week. The basic assignment is to read through the first 3 chapters of the SACS book and write up a 2-page double-spaced reaction paper. So the paper should be broken up into 2 parts. In the first part, students, I'm asking you to go ahead and summarize the first 3 chapters very quickly, very briefly. And the second part, you'll identify 1 or 2 themes from the reading and then provide your reaction to those themes. So very quick and basic assignment about the readings. I will be grading on your writing as well, so please pay special attention to things like clarity, specificity, avoiding redundancy, if you can keep those principles in mind as you're writing the paper. Also, generally speaking, active voice is going to be preferred to passive voice. So saying, I wrote the paper, as opposed to the paper was written by me, that's a difference between active versus passive voice. Active voice is going to be preferred, generally speaking. And also, if you can keep the paper formal, so avoiding contractions, for example, and avoiding the type of tone that you might use in maybe texting a friend. If you can dial it up a couple notches in terms of the formality, I think it'll work better. Your paper will be more effective if you keep to these principles. So moving into this week's outline. So we'll look at the U.S. healthcare system. I'll touch briefly on the healthcare reform bill that was passed in 2010. I'll look at some of the inadequacies, inequalities in the current system, and then we'll look at Medicare and Medicaid, how those programs operate. We'll get into discussion of the public health insurance system. There'll be just a brief note on the private system. We're not going to get too deep into private healthcare in the U.S., but the last section we'll look at one of the primary issues, one of the primary policy issues, and that's with respect to cost and quality. And the balancing of the two. So the basic notion is that costs keep escalating, and we're trying to maintain those costs, but not necessarily at the expense of quality. So that's the tension that we currently see. And so we'll discuss that in the last part of this talk. So we do have a new healthcare system, so to speak, in place. We have the Patient Protection Affordable Care Act that was passed in 2010 and signed into law. The bill was upheld by the Supreme Court. The constitutionality of that bill was upheld this summer. So this is a 1,200 pages piece of legislation. It's complex, it's comprehensive. There's really no part of the current system that's unaffected. So doctors, hospitals will certainly be affected. Consumers, patients will certainly be affected. And of course, taxpayers will be affected. We have to be able to pay for this system. So why should social workers care? Well, I note various justifications in your slides. So at minimum, many social workers end up going into the healthcare setting. So with an eye towards preparing for your futures, I think it's incumbent upon us to learn something about healthcare. The fact that as taxpayers, we're going to be affected indirectly. So there's various justifications for why we study healthcare in a social welfare policy class. And you can look at those, the other justifications that I offer in your slides. In terms of the current system, I think this is a system that we can characterize as both inadequate in some respects and unequal in some respects. So looking at some of the numbers, especially in the way of health insurance access, so I distinguish between health insurance access, healthcare access. We often confound those two issues, but certainly in the way of health insurance access, there are notable inadequacies and inequalities in the current system. In terms of inadequacies, all we need to really look at is in terms of the uninsured in the U.S. population. We're currently at 15.7% of the population being uninsured. It is a slight improvement from past years, but it's still certainly significant. In terms of the absolute numbers of people without health insurance coverage, we're upwards of 49 million individuals without health insurance coverage. If we're looking at people who are uninsured for even part of the year, for part of the past year, that number is a little bit higher. And even in terms of persistent lack of coverage, we have upwards of 30 million people or individuals with persistent lack of coverage. So these are numbers that point out some of the inadequacies in the current system, that the health insurance systems aren't really covering the extent of persons that we'd like for them to cover. In terms of health insurance inequalities or disparities in the system, we can see disparities in terms of age, race, income, and education. In terms of age inequalities, the system, what's really glaring is in terms of the working age population. The working age population is not covered by Medicare or Medicaid, at least up until healthcare reform. So we do see that the working age population is much more likely to be uninsured relative to kids and seniors. Uninsurance rates among seniors are among the best, so they're typically going to be less than 2% from year to year. In terms of race inequalities, Hispanics are much more likely to be without health insurance coverage relative to whites. They're 3 times as likely as non-Hispanic whites to be without health insurance coverage. We also see income and education disparities. Those with less than a high school education are more than 3 times as likely to be without health insurance coverage relative to those with the high school education. And certainly the poor, those who fall below the poverty cutoffs, are much more likely to be without health insurance coverage. I point out in your slide some of the uninsurance rates, looking at the most recent data that we have available, released by the Census Bureau. So for those under age 18, the uninsurance rate is 9.4%. For those in the working age groups, 19 to 25, the uninsurance rate is 27.7%. For those in the 26 to 34 age bracket, it's 27.5%, and so on and so forth, the various groups. So this is just pointing out in numbers what I've explained with plain language. And then, of course, senior 65 and older, the uninsurance rate is currently at 1.7% as of the most recent data. In terms of race inequalities or disparities, white, not Hispanic, those identifying as such, the rate is 11.1%, for blacks 19.5%, and then for Hispanics 30.1%. That's an improvement over past years, but still much higher than white, not Hispanic, or blacks. So we look at the public health insurance system. We're looking at Medicare, Medicaid. Medicare, this is the social insurance program. It's not income contingent. This is the program for seniors and persons with disabilities primarily. So there are various pathways into Medicare eligibility. You can qualify on the basis of age if you're 65 and older. If you've been receiving SSDI for at least 2 years, you may qualify. Also, if you have end-stage renal disease or kidney failure, you can also qualify for Medicare. Medicare is broken up into 4 major parts, parts A through D. Part C is a Medigap program. These are intended to fill gaps in coverage that parts A, B, and D don't necessarily provide. But primarily, we look at parts A, B, and D. Part A is your overnight hospital stay. So it'll cover overnight hospital stays, some skilled nursing home care, and also hospice care is financed, is covered under Part A. Part B will provide your doctor visits, will cover your doctor visits, your diagnostic testing, x-rays, things of that nature is being provided by Part B. Part B is a supplement, by the way, to Part A. Part A is the mandatory component. Part D is another supplemental component. This is the prescription drug program that was implemented in 2006, providing coverage for prescription drugs that seniors have to pay for. Now, a little bit about the financing arrangement of these various components. So Part A is financed through our Fica Tax. We had mentioned the Fica Tax before in the context of Social Security. This is the 1.45% tax that's assessed both on the workers and the businesses. This is being used, those revenues are being used to finance these overnight hospital stays and all the other benefits that are provided under Part A. So much like any other insurance plan, there's a deductible. The deductible comes out to about what you would pay for an overnight hospital stay, which is about $1,100 as of 2010. And then anything beyond the first night stay is going to be paid for by Medicare Part A. And then there's a cost sharing. There's a cost sharing between the Medicare program and the beneficiaries if you stay overnight at hospital for longer than 60 days. Part B, I had mentioned, covers doctor visits, diagnostic testing, x-rays, and things of that nature. This is a supplement to Part A, so it's not something that you would automatically qualify for. This is, you would have to pay a premium to opt into this plan. So the premium for 2010 was $96.40. Most people who receive Part A do opt into Part B because that $96 premium is much better than you're likely to find in the private market. And there's also a deductible here as well. The deductible for 2010 was $155. Part D covers your prescription drug benefit, and the financing there is noteworthy, I think, in the way of what's called the donut hole. So it's a somewhat, many characterize this as sort of an awkward financing arrangement, but the first $310 of prescription drugs is paid for by the beneficiary. So much like any other deductible that you might pay, those initial costs are going to be borne by the individual receiving the benefit. But anything from $311 to $2,830 is going to be paid for by the Medicare Part D program, where 75% of those costs are provided for by the Medicare Part D program. And this next tier is where we see the donut hole is from $2,830 to $4,550 of prescription drug costs. That's going to be borne entirely by the individual. So that's a huge gap in coverage, and we characterize that as the donut hole, like I had mentioned before. And then we have catastrophic costs, so anything in the way of costs exceeding $4,550, that's going to be borne by the Medicare Part D program. So 95% will be borne by the program. So just one note about that donut hole: it will be filled eventually. So gradually, we're going to fill that donut hole by 2017 with the recent healthcare reform bill. I point out some of the major changes under the Affordable Care Act in terms of the Medicare program. The primary change is that we should expect to see an increase in the Medicare tax, in that the FICA tax 1.45% tax will be increased 1 percentage point beginning next year. That's 2013 for those individuals who earn more than $250,000 a year. That's the most notable change. And we did see a temporary reinsurance program initially that was intended to provide coverage for those with a gap in coverage between ages 62 and 65. But we've closed the program since we don't have the funding that's necessary for this program any longer. But we just note that this was part of the plan initially under the Affordable Care Act. We have Medicaid, which is, of course, a public assistance program, so it's means tested. It's state administered, which means that states can operate their programs how they see fit. There are certain conditions, of course, but it's going to be different from state to state. Most Medicaid programs will differ from state to state, is the point that I'm trying to get across. What's notable here is the financing is going to be different, of course, from a social insurance program. The federal government shares in the cost of administering the program. They're going to support anywhere between 50 to 80% of the cost of the Medicaid program, and that formula is based on state wealth. So where per capita income in a state is high, the federal contribution will be lower, and vice versa. So where per capita income is lower in a particular state, the federal contribution will be higher. And so that range, once again, is anywhere between 50 to 80% of cost being supported by the federal government. Because these programs are run on a state-by-state basis, eligibility varies from state to state, but typically the rule is 133% to 200% of federal poverty. That's the cutoff, and it often depends on how old your kids are. If you have young kids, kids under the age 6, kids who are between the ages of 6 and 18, these cutoffs will often differ. And of course, we noted that the working age population is not covered currently under the Medicaid program, though that gap will be filled eventually. And then seniors, there's various cutoffs for seniors in terms of the percentage of the poverty line that's going to be used to establish eligibility, and that's going to differ from state to state. We note the composition of Medicaid enrollees. Most Medicaid enrollees are going to be kids. They make up the largest percentage in terms of the composition, but in terms of costs, it's much more expensive to cover seniors and persons with disabilities under the Medicaid program, and that's largely because of the long-term care that we provide under the Medicaid program. I'm referring to nursing home care that's provided for persons with disabilities and seniors. In terms of the benefits or services that are offered under Medicaid, there are some mandated services, those services that must be provided. Doesn't matter what state you're in, but there are some optional services, a whole listing of optional services that states may pick and choose from. But in terms of the mandated services, we're talking about things like overnight hospital stays, those things that we mentioned that are provided under the Medicare program. overnight hospital stays, doctor visits. One thing that's different, of course, is that long-term care, so nursing home care, will be financed, will be paid for by the Medicaid program, unlike Medicare. And pregnancy services, postpartum services are also under the listing of the mandated services that are provided under the Medicaid program. Some of the notable changes with the Affordable Care Act in terms of the Medicaid program, most notably because of the fragmentation that we have from state to state, we've tried to make these programs more uniform in nature. And so with the Affordable Care Act by 2014, we should have a very basic cutoff, 133% of poverty. Anyone who falls below that cutoff becomes eligible for Medicaid under the new Affordable Care Act, the new rules. We do have uniform benefits. There should be a benefit floor. This is still, the details here are still being worked out, but that should be more uniform across different states. And there's some bonuses. There's some bonuses that are being provided, incentives for doctors to go into less well-paying positions and into underserved areas as a part of the Affordable Care Act. So these are some of the most noteworthy changes that we should expect to see under the Affordable Care Act. Just a brief mention of the Children's Health Insurance Program. This is a supplemental program to the Medicaid program. So typically the way this works, if those who don't qualify for their state Medicaid programs, they may qualify under their state Children's Health Insurance Program. So one example of how this might work, Medicaid provides coverage for kids and their families up to 133% of poverty. And then the CHIP program would come in and provide coverage for those with incomes between 133% and 200% of the federal poverty line. So this is, once again, a supplement to the Medicaid programs. There's different ways in which the states operate these programs. There's different options for states in administering these programs. Just one note on the private health insurance system. So we can characterize the private health insurance system as being regressive in nature, and this is due to the tax treatment. If we look at the federal income tax structure and how it treats private health insurance benefits, most notably the fact that private health insurance benefits aren't subject to federal income tax, that's going to be much more favorable for the higher income worker relative to the lower income worker, because higher income workers are subject to higher marginal tax rates. They're saving quite a bit more than the lower income worker by the fact that these health insurance benefits are not subject to tax. We don't treat these like other forms of income. And so once again, the bottom line here is that we have a highly regressive system when we're looking just at the private health insurance realm. Just a note on health insurance coverage, we characterize the system as largely private in nature. If you look at the numbers in terms of health insurance coverage, 63.9% of the U.S. population is covered under a private plan. So that right there, I think, is evidence of the fact that we have a largely private health insurance system. Medicare coverage, 15.2% of the U.S. population is covered under Medicare. Medicaid, 16.5% is covered under Medicaid. And we had noted before the uninsured population, uninsured, stands at 15.7%. These are not mutually exclusive, so they don't necessarily add up to 100%. So people can be under more than one category here. But the basic point in this particular slide is that we have a largely private system. The last piece here is with respect to the policy issue, the grander policy issue. That's that we have escalating costs that we're trying to maintain or minimize, but at the same time not compromise the quality of the services that we offer. And if you look at the numbers, if you look at the public health insurance system, we spend almost $1 trillion on health insurance programs, our Medicare and Medicaid programs, so $521 billion for Medicare as of 2010. Medicaid, we spend $317.9 billion. That's 2009 data. So we spend significant amounts of money in our public health insurance system. If we're looking at total spending, U.S. healthcare spending as of 2000, we're using $2,001, so adjusted for inflation. You'll note that spending consistently increases across time. So anywhere between 21% and 46% increases every 5 years in the spending that we do in total spending. We can look at different numbers. We can look at per capita spending, and it paints a similar picture. anywhere between 16% to 38% increases every 5 years in the way of health expenditures, significant increases across time. And if we're looking as a percent of the economy, so as a percent of GDP, just a different indicator of spending, once again, we see significant increases. We were at about 13% of the GDP in terms of our healthcare spending as of 2000. That number went up to 16% and is projected to rise to 20% by the year 2015. If we're looking at healthcare spending across different rich countries, we spend more on healthcare in the U.S. than any other industrialized country. So the U.S. spends 16%, as I noted, in terms of its GDP. The next highest country is France at 11%, so not nearly as close as what the U.S. is spending in terms of our GDP. If we're looking at per capita income, another indicator, we spend upwards of $7,000 per person on healthcare. The next closest country is Norway, which is at $4,700. So whichever way you cut it, we're spending much more on healthcare in the U.S. across time and across different national contexts. And then I provide some additional information about the extent of what percent is in fact public spending. Much lower in the U.S. than other countries. 45% of spending is on public health insurance or health care, as opposed to a country like Norway, which is at 84% of spending, which is in the public sector. So this, of course, begs the question of what explains these escalating costs. Well, we have an aging population. The baby boomers have just retired in 2012, and so we saw how much more expensive it is to cover seniors and persons with disabilities in the context of Medicaid. So that's one particular reason. We have rising healthcare salaries that we have to pay for. There's medical malpractice litigation. There's pharmaceutical litigation that keeps these costs escalating. There's the health insurance companies, the third parties, the middlemen that we have to pay for, their profits. That's going to contribute to costs. Technology keeps getting better. So there's numerous reasons or numerous factors that are identified as contributing to the escalating healthcare costs in the U.S. But we would think that those costs, the fact that we're spending so much over time and across different contexts, relatively speaking, that we would have better quality healthcare in the U.S. And if we're looking at different indicators, for example, if we're looking at wait times, we have some evidence that the U.S. system is somewhat better. So we have shorter wait times in the U.K. We have similar wait times for elective surgeries as France and Germany. So that's some evidence that our system may be better. But in terms of traditional indicators, namely in terms of life expectancy, in terms of infant mortality rates, the U.S. is really no better than any other industrialized country in terms of life expectancy. And in terms of infant mortality, we're one of the worst in terms of the developed world. Among the developed countries, we have one of the worst infant mortality rates. So despite all the spending that we do, I point out that according to different indicators, traditional indicators of well-being, the uninsurance rates, for example, we have one of the higher uninsurance rates in the developed world. We're still not doing a very good job of covering our population. So we'll wrap up the lecture here, and next week we'll get into international poverty.